So yeah, thank you all for joining and for coming. We're really excited to kick off the semester with more virtual seminars in computational medicine. Our goal is to record these, and we're starting to slowly put them up on the YouTube channel. So if you can't attend any seminars in the future, please know that they will be recorded. They'll be available on YouTube on the Pratt Engineering channel so that you can review them in the future. And we also want this to be something you can access, outside of Duke, and please feel free to share the information for this seminar series beyond Duke. As a reminder for everybody who is on campus and kind of braving the cold today, we will have a coffee hour after this session in Wilkinson in the lobby. You'll have your chance then to meet the speaker and interact with other people from the broader computational medicine community here at Duke as well. So we'd love to have you come. There's donuts and refreshments and coffee as well. So we'll jump into this. We're leading off the semester. Trying to set this up. We're trying to lead off this semester with the first talk from Dan Buckland, which should be a really exciting talk, as you can see, titled Successes and Failures in Implementing Machine Learning Models at Duke Health. Dan is an assistant professor here in emergency medicine and mechanical engineering. He's an attending emergency physician at Duke Hospital. So this is really our first talk in the series coming from the medical side as well. He's the director of the Duke Acute Care Technology Laboratory in MEMS, where he does research in automation and in safety critical systems. And he's the medical director for the Department of Surgery Laboratory for Transformational Administration. He is also the deputy risk manager for the human system risks at NASA Johnson Space Center, but he'll be giving his talk today in the context of his role here at Duke. With that, I'm going to turn it over so you can hear more from him and let him jump in. Thank you so much for joining us.
Thank you. So I might be trying to be too clever with Zoom here. So I'm going to do the newscaster kind of view for a little bit. If it gets distracting, please stop. But with it, I should be able to see your chats. And if someone wants to try the thumbs up or whatever, or a hand up, and let me see if I can see that. Someone could put a hand up. I saw David's laughed. Amanda raised her hand. Okay, so I can see this stuff. Great. All right, perfect. So feel free, if you have a question or anything, I will be able to see it, and then we can address it as we go. I only have about 32 slides, and we have this amount of time, so I won't take the whole time if we don't ask any questions, and then I'll just talking at a screen. So please do. And yeah, so I'm trying this this picture-in-picture kind of thing. It is actually working very well. I don't have hair that's not being cut off, and so we were going to go. We will talk about these kind of things. So as the title of the talk is Successes and Failures in Implementing Machine Learning Models at Duke Health. I'm like, was that a question? No. So the reason I'm talking about this is this group, I've seen many of these talks before. Everyone's doing kind of foundational, groundbreaking kind of work in machine learning and computational kind of methods, and all very exciting from a clinical point of view. However, when I watch these things, I'm like, oh, I'm never going to use that. Not your talk that you gave, but of the other talks. And so I'm kind of we've tried to put some very kind of rudimentary machine learning models deployed into the health system. And I want to go over why these things have worked, and more importantly, why these things have not worked in the past. So you can kind of learn from our failures and our lessons learned, and going forward with that. So that being said, who am I? Like Amanda said, clinically, I'm an emergency medicine physician. I work in Duke Hospital. Hopefully you never have to meet me in my clinical practice, but I work 1 or 2 days a week in the emergency room, where we have lots of technology and computational problems. I do have an appointment in mechanical engineering, where I do a technology lab, and mostly we work on data science and robotics with the overall goal of trying to what's the ways and the implementation science behind automation and safety critical systems. And so that's the kind of overall arc of the stuff we do in mechanical engineering. So then I have an operational role in the health system itself, in the Department of Surgery. So the Laboratory for Transformative Administration, which will be the incubator for many of these projects you're going to see today. And in that, it's a group of data scientists, administrative folks, clinicians, data engineers, informaticists, all working together to kind of, with our overall goal of, we want people to be able to have surgery when they need it, right? And so the goal is to make it so when a surgeon says you need surgery, there is the technology and the resources and even a bed available when they decide you need that clinical indication. And then, as Amanda said, I also have a role at NASA, which is like 70% of my time. I am explicitly not speaking as my government role today. But if you come to the coffee later, I will explain all about rockets and what I do with them. That's kind of the teaser for the coffee afterwards. All right. So the bottom line up front, right? I do stuff in government. They always want this bottom line up front. And so we'll keep going back to these are the lessons. Feel free to screenshot or take this, but this is the list of my outline of what we're going to be going through, right? So how the model is only 10% of implementation. Models themselves are really good at predicting what we're already doing, right? And we'll go into why that may not be what you want to actually have done, right? That physicians, and here I'll kind of put down myself a little bit, and other physicians that may not be the customers that you want us to be or need us to be for the models you are developing. We'll go over the concept that language is different than vocabulary. That when you are trying to generate change in any kind of system, there's a reason the system is like that, right? And so there's going to be some institutional pushback about change you introduce into a system, even though everyone has the best plans to do these things. That when you make a model, that there are assumptions between the model and the user, and then if those don't align, those lead to lack of use or different discrepancies. And then this quote, for those who do engineering history, to engineer as human is a little bit of where's the engineering part of this, and what is it that engineers are doing their best contribution, from my view as a engineer, is to that. And so my background, I didn't really get into that, is, so like I said, I do the clinical role and I have those other roles. My training is I have a PhD, other than an MD with emergency medicine, I have a PhD in aerospace engineering, which is why I also do the NASA work. And so that's my engineering background coming into this. All right, let's start. So when I say the model is only 10% of the implementation, what does that mean? So we have seen in my different clinical roles, people bring models to us a lot, right? Often they are amazing in the context that they were developed in. The work to make that use, so when I see a patient or when the surgeons see a patient, that it changes anything we do about what that patient is, the model itself is only 10% of the work it takes to do that, right? And to show you that, so two of the models we're going to talk about, one's we'll go over 3 or 4, is on the left, over here, not the one behind me, the one over there, that's what it takes to get from when I work in the emergency room, the step it takes from you arrive in the emergency room and when it takes you to get to a bed in Duke Hospital, right? Those are the numbers from pre-COVID. Those numbers go back and forth, but it takes about 8 hours on average in 2019 from when you first arrive in front of the emergency department to you get wheeled out into a bed elsewhere in the hospital, right? The goal for a lot of emergency medicine is to reduce that 8 hours, right? And so, but I'm going to talk about a model that we did in the emergency department to predict whether you need a bed or not, right? And so that is only one tiny piece of this whole chain about what gets you admitted to the hospital, because things need to happen at every step of the way. And so just knowing you need a bed in the hospital is really a small portion of that. And then right behind me is what it takes to get the decisions that have to happen and the people that are involved to get you from, if you are at an outpatient clinic and you see a surgeon and the surgeon's like, I think you need surgery, right? There are many steps that also have to happen to get you in a bed in the operating room. And these are the kind of steps in there. And so another project we did, we'll go over, was just, it simply predicts how long that surgical case is going to take. And that happens in the clinic, in that big box in the clinic, right? But there's all these other steps in the way that can impact how long that case is going to take and whether it's going to happen at all, right? And so I say 10% up above, but that's really, at this point, we started when we first started the work that I've been doing, we guessed it at 20%. And I'm probably gonna have to revise these slides again to make it only 5%, right? And so when you are sitting there kind of grinding the gears in your model to make that model, that receiver operating curve or your AUC just a couple points better. The saying that the model is really a small part of the overall implementation is it needs to be good enough, right? That's the lesson is you can spend days and weeks and months making your models better in terms of precision, because that's the report that a lot of people see. But that's not going to make a difference in the clinical implementation if there's certain thresholds that it doesn't meet, right? Going from, and we'll go over this a little bit more, going from a 60% accuracy to a 70% accuracy, unless you're doing population modeling, will probably not make a difference in any individual person's care, which is somewhat depressing to understand. As a 10% improvement would be great, but that really, it takes a lot to make a clinical impact, and that probably wouldn't do it. So also my structure of this is, if you have questions as we go through those things, please feel free to ask them. But that's the, yeah, that's what this one is. Okay. Models protect the status quo. So what do I mean by that? So models are based on clinical models, and medical models are based on medical data, right? And so we have everything, when you are making, say, clinical decision aids or decision support or predictions or something like that, baked into those models is the beliefs we already have about how a medical system is supposed to work or how clinical decisions work, right? So if everybody's been treating pneumonia wrong, there really isn't a model that's going to say, oh, this is a group we've been treating incorrectly, right? Because it's going to be based in that. You have to make an active hypothesis-based decision of, I think this is wrong. You have to do things differently. And then you can use, I've seen very good implementations of models that say, okay, we were not able to get a high enough end to make these predictions. So there's modeling we can do to kind of extend that. But you do have to remember the first place that if we are doing something wrong, applying a model into the health system will bake that assumptions that you didn't understand or didn't know existed into the future care of use of that health system's resources. And so this goes into equity and diversity and stuff like that, right? If we have been under-treating or poorly treating a demographic or population, that's going to show up in the clinical data, right? And we may not have race or gender or zip code as an identifier in the original clinical data that we are building. And if it's not in there, then we are going to perpetuate that inequity going forward, even though it's seen as, oh, well, the model's doing it. It's not that. And just to remember, and there's lots of work on this that I don't necessarily do, but we take advantage of and pay attention to, is the assumptions that go into your model may not be what you think they are, and you have to be more skeptical of the source of your data than you would think. And so other ways to think about this is the static. So another model we did, none of the other two I mentioned, was there's a clinical condition called small bowel obstruction. Basically, your intestines stop working. For a variety of reasons, but basically you cannot poop, you cannot fart. And that is a clinical problem because it will all back up and cause significant discomfort and vomiting. Sometimes a tumor mass will cause that, right? And that's a thing that needs to be surgically repaired. Sometimes it's just that for a variety of reasons, your bowel is shocked. There's some shocks and it will clear itself. But it's still stopped at the moment that you are that uncomfortable, right? There's other things. If you had a prior surgery, every time you have a surgery and surgeons have to enter your abdomen, there's healing that occurs, and those healing could cause adhesions, which can cause your bowel to tie itself up in knots, basically, right? So there is a range of things that can occur that lead to the same clinical outcome of your small bowel is obstructed, and this is a medical emergency. Sometimes surgeries need to repair, sometimes it is not. But knowing ahead of time which patients are is very difficult to do clinically. And so at Duke, for instance, anyone with a small bowel obstruction gets admitted to the surgical service as that it's found on CT. And the clinical decision is made that, okay, they're obstructed, they go to the surgical service and the surgeons watch them until and if they get better, they get to go home. If they get worse, then surgery happens. And so lots of effort was made to use modeling to decide which of these people are going to be need surgery or not, right? Because if they're not going to end up needing surgery, and I can predict they do not need surgery, then they do not need to go on a surgical service. They can still need to be staying in the hospital, but they can go at a different part of the hospital that doesn't take surgeon resources and time for a non-surgical problem. And so one of the first things we thought of, okay, well, let's use the CT scans, right? Because all the clinical information is in the CAT scans themselves to decide if they need surgery or not. Because that's what the surgeons do. As an emergency room doctor, I will call the surgeons. They will come down, they look at the CAT scan and the CT scan, and they look at the patient. And they're like, I think you're going to need surgery or not. Let's put them on surgical service, or this person definitely won't. Maybe they can go be better served than other ones. The problem is with the data is, as of yet, I don't have any models that are out there that use CTs that we can implement in workflow to make that decision, right? I can't replicate a surgeon's decision-making ability with cross-sectional imaging in bowel obstruction yet, right? These are very complicated images that can be read in many different ways. And so I can't use that. Then the next step is, well, the radiologist has to read it, right? They have to write down what they think is going on. Let's use natural language processing. Let's use keyword searches to use that to predict what happens with small bowel obstructions. Well, that's a good idea. We found some utility in that. The problem is the way at Duke, again, this is very Duke specific, but every medical system has its own issue. The radiologist read does not enter the electronic medical record until almost 24 hours after the CT scan is read. So the patient has already been decided, as the surgeon has already made their decision. And so a model that can make a decision 24 hours after the surgeon is not helpful. And so we need something that can read the CT the same time that can read the same time that the surgeon does. We logistically could not figure out how to get that going and happen in the Duke Health electronic medical record and backend system, right? So there's lots of great models that I'm sure that can do this. We couldn't use any of them because we couldn't find a way to give a model access to both clinical electronic medical record data and to cross-sectional imaging data at the same time to make a prediction, or to even the radiologist's interpretation of it, right? And so that just wasn't available to it. And so first, then we still had a problem that we needed to solve though, right? Were there patients who needed surgery and the ones who didn't? Did we know at time of diagnosis of bowel obstruction that they did not need surgery? So maybe it's just in the electronic medical record data itself, right? And so let's see if we can find a natural breakpoint of the people who need surgery, the ones who don't. And so this is just retrospective kind of data, right? And so no prediction at all. And so basically we said, can we just bake them into populations, right? So we had all this plans of modeling for prediction and stuff like that. And so the blue in this one is that they never needed surgery. They were admitted for a bowel obstruction, but they didn't need surgery. And red is that they needed surgery. And so what you can tell by that graph up in the top left is that very few people actually needed surgery, right? So if I make a model that says no one needs surgery, it will be mostly right? Will it be right enough? No, but it will show some really good AUCs and predictive value. And so the same graph below is the log scale of it to show. But you can see the majority of that population, if you don't need surgery in the first 2 days, you probably don't need surgery. And so is there a way to just say that, is there a way to predict those people? And then the other thing we said is, okay, once you make it to 2 days, or we've made it 48 hours in, then do you end up needing surgery? And basically, very few people who made it 48 hours without needing surgery ended up needing surgery. And so this is I would call this one then and then here's the advanced analysis of the trees about how to do all this stuff. But basically, once you don't need surgery, you continue to not need surgery with pretty good specificity and predictive value of that negative event occurring at that 48 hour method. But it turns out, I'm going to call this a failure of the machine learning model, because what we ended up doing required no modeling at all. I have a pathway in the Duke Emergency Department where I can just kind of watch somebody for 24 to 48 hours without needing to obligate them to a surgeon's bed or a non-surgeon's bed. And so we then use this data to make a decision of, well, let's just say that, and it also doesn't take an emergency room bed. I have a holding and observation area is what it's called. And so what it took was that we decided, okay, maybe this isn't a machine learning problem anymore, right? We've done advanced analytics and analysis to show, but maybe we don't need a prediction. Let's just, at the time the surgeon is looking at the patient, if the surgeon himself believes that this person isn't going to need surgery, we have a place that we can now put them that we just wait them out for 48 hours, right? If they get better in those 48 hours, they go home. If the surgeon sees them again at the end of the 24 hours, says, I still don't think you need surgery, then go to a non-surgical bed and saving some resources. But if they get worse at anywhere along that point, the surgeon is still around and available to make a decision, right? And so this was a machine learning failure of implementation, because the idea was we were going to have this fancy model that did all these things. But it was a success in that we figured out a way to use that data to make some clinical decisions to provide a new pathway for people to get more efficient and useful care. And so why am I connecting it to surgery, to models preserve the status quo? Because nowhere in any of this did I say that we could do an analysis of whether people were getting surgery who would have ended up getting better without it, right? I don't have the ability, but you can see how people can make that assumption based on the analysis we did is, oh, people who get admitted to the surgical service probably needed surgery or at a higher risk of surgery. There is nothing saying that people were getting surgery who would have gotten better on their own. That population definitely exists, but I don't have a way to analyze that in the way I asked the question. So you got to be very careful of what you're doing. It could have been that almost no one needs surgery. I don't think that is true, but I don't have a way to analysis because I don't have a way to set up a natural experiment of let's wait them out, because that ends up adding more risk. But we're just building in institutional barriers to even now finding that out. And so that's why I'm saying that you have to be aware of the downstream effects of your decisions, of the models themselves. Any questions on this stuff so far? Nope. Okay. Physicians may not be the ideal target users. What does that mean? So I just talked about the small bowel obstruction discussion, right? So physicians were the customer or were the users of that, right? Was it to tell a physician this person won't need surgery? Because we were trying to be very careful that we weren't telling a surgeon that a person would need surgery. We were telling emergency room physicians that a patient may not need a surgeon. Well, probably won't need a surgeon, right? Those are two different ways to formulate the same sets of data. So you can tune your modeling to be very good at negative predictions. It's what we asked it to do. But that all was clinicians and physicians, which is kind of the stereotype of what to do with these computational medicine models. So, but the physician is not always the ideal target user. So here's I talked a little bit briefly about how we had developed a model in the emergency room to predict admission from the emergency room to inpatient intensive care unit. So our first thought was this will be a very helpful model for emergency room physicians to know before they even go see a patient whether the patient's likely to be needed to be admitted or not. Good. We published it in a clinical journal. Everyone liked it. There was lots of applause. And then I said, okay, it was validated. The folks at DHI did excellent work at designing an interface for it. And said, okay, now let's use it. Let's change how clinical care is being delivered based on this well-validated, well-developed model with a good clinician interface. So just an example of how well we did. So we ended up generating this Tableau dashboard that shows every bed in the emergency department and every person in that bed, whether they were high risk, low risk, or medium risk for needing a bed in the hospital, right? And whether also you're going to go to the ICU or just to the inpatient part of the hospital, a different level of care needed. Great. And then we even brought in some more kind of advanced human factor stuff on the over right here. It kind of predicts how many people because the thinking was, well, individually, there's too much variance, right? The model will be correct or it won't. Let's give estimates of how many people need beds, right? So how many in the hospital, how many people in the emergency room beds? So that way, what happens in the hospital is every once in a while, the people who control bed allocation will say, hey, emergency room, how many beds do you need? And so it's usually based on the charge nurse walks around and says, do you think this person can do not? They build up a list and they say, we think we need 10 beds, right? So the goal was, okay, let's just take that as a group of, I have probabilities for everybody. Let's just make a group estimate of how many people are going to need beds. And that what get delivered to the bed czar is what they're called at Duke, right? And so the physician isn't the target, it's the bedsar. The bedsar can just be shown this, and we will give them a range of estimates of, on a bad day, we would need 13 beds. On a good day, we need 2 beds, right up there. And then in the ICU, we would need this range as well, right? It gives a median, a mode, and it gives a range, right? And so then it lets you bring in other factors to do it. Great, everyone liked it. We surveyed people who would use it. Everyone said, yeah, this is a great idea. I'd be happy to use it. No one touched it, right? We had metrics to say how many people logged into this Tableau dashboard and used it. Almost no one except for me and a couple of people who knew what this model was. We presented it to the faculty. Everyone, yeah, that's great. I think I'm going to use it. No one ended up using it. So like, okay, maybe it's the interface between it's the way this is laid out, right? We're showing people point estimates or showing these ranges. They don't know what to do with them. Let's break it down we had another clinical problem that came up. This was actually COVID. Our waiting room was blowing up. We would have lots of people in the waiting room. We were trying to treat all these people in the waiting room. Let's just show the waiting room. And so that way the clinicians who are supervising the waiting room can easily pick out who's going to need a bed so they can expedite their care, who's going to be discharged so they don't end up taking a bed, right? We built this whole new interface, right, of the same data, presented it in a different way. And so that way you can easily make this list of who's going to need admission to the hospital, who's not, out from the waiting room, right? Because we thought, okay, maybe the problem was I don't actually control who gets a bed in the hospital. So a interface that shows me something I can't control as an emergency physician doesn't it's not helping. But I control the waiting room and the beds in the emergency room. So let me try to do something I can't control, right? And so this interface was developed, right? So if they were red, they definitely were going to be admitted. If they were dark green, they definitely need to be discharged. So that's something I can use to manage the waiting room. No one used it. And then we had, with COVID, different things. We had high waiting rooms and low waiting rooms. This model ended up, everyone who got shown it said, yeah, this is something I definitely would use. But when we looked at who was actually accessing the model to use it during a clinical shift, it never ended up being used. And so I'm going to call this one, it was very successful, and we got a clinical paper out of it, which is not normal for medical modeling, but failure in that it didn't actually affect people's care, right? And so why are physicians maybe not the best model for this kind of stuff? And so I use this paper a lot, so it's not just me doing this. So risk, and I do a lot of work on risk. Humans are bad at using risk numbers. Physicians are humans. And so we do a lot of math as physicians, very simple math. And in the emergency room, math I have to do is sometimes just basic arithmetic, which you would think is not that hard, but I want you to try to think of those tests you do that you did like in elementary school, the time test where you just had to do simple multiplication just over and over again. Sometimes we do a lot of that kind of stuff, but people are yelling at you and someone is getting CPR right in front of you. That makes you significantly less good at math and unsafe at doing it, right? So even in our job, it's hard to do math in the moment. So if you show someone a risk score, it is very hard for us to do it in the moment. Population level is something separate. I'm saying as an individual application to a patient in front of them. And then this group actually took, you can see, in 215 physicians, and this was outside of a clinical context, but they were giving them clinical problems. And the problems they were giving them were of the nature. They would say things like, anyone with a cough has a 10% chance of having a something on their x-ray that's not normal, right? So 10% of cough have something on their x-ray. And then it said, okay, 50% of things on x-ray are cancer. These are not real numbers, don't go with that. But that was basically, it was to make the math easy, right? So 10% of people with a cough have a mass on their x-ray. 50% of x-ray masses are cancer. Then I would ask the clinicians, what's the percent chance that someone with a cough has cancer? And their answers would be of the order of 15 or 20%, right? Where if you just multiply 10% by 50%, should be 5, right? It was presented like that, and they just would give estimates that were not that. And so there's nothing inherent about physicians that makes them bad at it. It's just humans are really poor at making risk-based math probability things. Humans are just bad at probability. The lottery exists because humans are bad at probability, and physicians are humans. And so if you need to cite something, this is not my paper, that says that maybe we don't want to rely on people at the point of clinical care to make risk-based clinical calculations, this paper is an excellent way of doing it. All right, so then back to my model. For there's some interesting stuff that came out of it of what was the things that were most predictive of someone needing admission to the hospital, and what was the most predictive of needing ICU. And then this is non-intuitive for clinicians, although it might be intuitive for other folks, is age. That is intuitive, right? And this is feature importance. This isn't a linear relationship, but if you are very old, you are likely to need admission to the hospital. And so that's really what that's reflecting. The second one being the white blood cell count is, if you ask most clinicians what's most predictive of needing admission, they would not point to the white blood cell count. They would say something like a heart rate or blood pressure or something like that. The problem is the quality of the data of heart rate and blood pressure is just not as consistent as white blood cell count. Your white blood cell count is probably correct compared to what it is in reality. Any given heart rate that is in the electronic medical record, or any of the vital signs, so heart rate, respiratory rate, I think that one itself just has a higher likelihood of not being as true to reality as lab values. And so that's why in a analytic or in an investigational hypothesis-driven kind of thing, white blood cell and hematocrit, which is HCT, outweigh the vital signs as to how important they were to predict admission. And then the fourth one is LOS is length of stay during previous ED discharge last year, right? So if you were in the ED for emergency department for a long time, you probably need to be admitted now that you've come back. And that's really what that's saying. And then you can read the list in very tiny type above with the papers available for those interested. And then ICU largely follows that same kind of thing. And so these are all interesting outcomes, but didn't make the model any more useful to us being used. I see a question from Zach. What kind of model are these feature importance calculated for? What methods used to calculate it? It's an excellent question. I'm going to refer you to the paper on, because I'm going to forget in telling you flat out from this. All right, and that's it. The model itself performed pretty well. Oh. All right. So language different from vocabulary. So I really like this phrase. Language is different than vocabulary. It's actually gotten from, there's a book, a really good book, blanking on the name of it, but it was about the integration of Durham public schools back in the 40s and 50s. But there was a quote in it that said that everyone was using the same, everyone was speaking a different language as each other. But unfortunately, they were using the same words in their language, in their discussions, right? And so it leads to a lot of miscommunication so even the word risk, right? If you ask a clinician what the word risk means and an engineer, those are two wildly different definitions of the same word test. The word failure even means different things to different groups, right? And so those words lead into a lot of different understanding and stuff like that, right? And so clinicians or engineers have said, oh, we can make this model better, but we just need to pull the data, right? Informaticists, that's their whole kind of job, is how to generate data from clinical electronic medical records, right? You're asking for tens and hundreds of hours of work to get the data in a form that can be used for predictive modeling or computational modeling. Decisions and assumptions are made every time that data is culled or categorized or cleaned, every step of the way. And that's going to impact the utility and outcome of your model, right? So you're saying, oh, we'll just get the data out, right? But the data exists, has its own assumptions, like we already talked about. And the steps it takes to make that data usable for whatever your purposes are also has a lot of assumptions that get put into it. Oh, let's just push it to production, right? Let's just put it out there. Okay, what does that mean? Pushing to production is, and we'll get into this a little bit more. It is not as simple as we would like it to be to say, oh, I have this great model that's validated and published, right? Now I want people to use it, right? Like I said, at 10%, it's only 10% of the work to develop that model. But saying, let's just push to production, that's many people's hours of work to get that into production and used and be reliable enough to be used in a clinical context. Reliable, not so much even as as precision and accuracy. Reliable means that that model is always producing data when I need it to do, right? So if I have a model that can predict if someone's gonna have a heart attack, but it only works in the mornings, that's not a useful model. And then high risk, like I said. The special point I want to make about 0.05. Clinicians are trained as to, again, this is a stereotype, probabilistic estimators, right? I already said they're not great at probability, but we still use probability to make a lot of decisions. So at some point in medical education, you get a statistics class, right? Which is good. But that 0.05 number just becomes, like in a lot of science that gets published, right? It becomes a thing, a piece of it. So there is a large assumption of how that translates into clinical use. When you give risk scores or probabilities, anything that's less than 5% is not going to happen. Anything that's over 95% is always going to happen. And then everything in between is 50-50. And so that's where I said this thing before of making a model go from 70% accurate to even 90% accurate. Great, lots of papers you're going to get out of it. In terms of individual predictability, probably not going to change a lot at a individual treatment level because we're at this 5 and 95% threshold, which comes from the statistics world, but it's just kind of how we think. And then when I turn that around and say, a 5% chance of happening, if you gave that to a clinician, they're like, okay, doesn't happen. Now, if I go to engineering and say there's a 5% chance of this happening, in most engineering, that means it's definitely going to happen, or it definitely needs to be planned for happening, right? So even that 5% threshold, where there's a lot of threshold effects that happen at 5%, clinicians and engineering and science treats that 5% wildly different, even though it has a threshold in each. And so that's what I'm talking about with language is different than vocabulary. Okay, and so like what I was talking about before, we'll have clinical data, we'll run the model, and then people will use it, right? That's an assumption. This is what it takes to use our model of how long a surgical case is going to take, right? That's all it does. It says, oh, based on what the patient is going to have done to them, this is how long it will take for that operation in the operating room to take, right? That's all it does. It still takes all of these steps to have the data available when the model runs, which only runs once a day because these aren't happening all the time, when patients are predicted to need surgery in the clinic. But even that takes all of these things. And each of these white boxes, for those of you who see these diagrams a lot, has a different owner in the health system IT structure, right? So they have different servers, they have different GPUs, they have different ways of getting data or not, right? Different ownership structure of institutes or different growth, different operational centers in the hospital. And so a server going down can defeat any of these steps, and different people get called at different times. But all the users end up seeing, and the users for our operational efficiency model is just the people whose job is to decide how long a case takes, right? If they see no prediction, they're like, well, this thing's not working. I'm just going to make a guess, right? And I'll show you some data later. We know what their guesses look like. We don't want them to make those guesses. But it's still knowing that this is something that needs to be maintained and owned. There's probably 5 to 10 like staff number of people who need to keep this thing going. It's not their whole job, it's a tiny piece of it, but it's still 10 separate people at least to keep this thing running so it's always available every day. Okay, pause again. Any questions? Can I get a round of thumbs up?
Yeah, this is great. I just keep going.
People are listening now. That's another question. I see we got 30 some people. Can I get a couple thumbs up just to know that you're still listening? Okay. Okay, so all right. I wonder how much of the disparity in the data feature importance flight count is due to user error when entering, collecting medical data. I would say probably most of it, right? So it's probably most of it. I think the variability in ground truth versus recorded data is just higher in these heart rate, right? So when you look at studies where the same diligence is put in the quality of the heart rate and into the vital signs and to the lab values, the importance of the vital signs goes way up, right? Someone who has a heart rate of very low or very high is probably needs medical care, and it is more reliable, right? So in the clinical setting, I can look at someone and I do my own sampling, right? I see the telemetry monitor right above them that says how well what their heart rate is, right? It's kind of going up and down, right? The electronic medical record only has a snapshot, right? It's like your Nyquist sampling. It samples once every, I don't know, hour, right? And so, but there's lots of variance in that hour, but I, in front of them, see them differently. So it's probably at a ground truth is very important. It is very important. The white count is just a snapshot, but in terms of reliability of that data that you can use for modeling, it's only as good as what it gets in the record. So yeah, that's a very good point. All right. What would you do differently at the start of your projects now that you know now? So next question. I think, so this is going to sound, try this something is to get all the stakeholders in the room. And the key is, and we'll kind of get to that a little bit. I'm going to get to that with the shared assumptions between model and users. But thank you, Brian. If I don't answer your question, bring it up again. All right, expect pushback when changing workflows. Like that. Yeah. So, like I said, I want to be very clear. What I'm saying when I say pushback, and I probably should pick a less loaded term, is not. It's not. These are not people saying I like how I work. I'm not going to change. Screw off. There's every system. There's another quote that I use a lot. Every system gets the results it was designed to get. Right? We don't have broken systems. We have systems that were designed because of the context and the reason they were designed, right? People respond to negative response, right? If I get an email saying you didn't write that note correctly or you didn't treat that patient right, I will probably make a bigger change than because I never get emails saying, hey, you did great there, right? I get them a couple times, but that's less of an impact of, oh, I don't want that email that makes me feel bad anymore. Right? We've seen that with mice and stuff like that. And so these people, the systems act in the way they act because of the incentive structure around them, especially in US healthcare. And so if your model suggests a change or recommends a change or would involve a change in workflow to use it, just know that there's institutional momentum to develop these things. So part of the answer to Brian is you have to spend much more time than you think understanding why the current system exists like it does than you think you're going to have to, right? The answers are not all in the data because even the data comes from a place that has those incentives built into them. And then also noticing the difference between individual applicability versus group means, right? So I'll call our operating room efficiency what's a successful thing, right? Because I have people making different decisions because of a machine learning model that's applied in the health system. What it took to do that was we have over 400 surgeons at Duke. In the months it took before we had people start using it, every surgeon at Duke got an email that said, here's what you said, how long your cases were going to take. Here's what this model that we're going to deploy is doing, and here's how long everything took, right? And in almost all cases, the model was more accurate than the surgeons themselves. Some of the surgeons were better. And so they would say, hey, well, I don't want to use this because I'm better than this model. And it let us kind of get these lessons learned from the surgeons themselves and apply that to their workflows, right? But almost everyone needed to be told, here's how this model works for you, right? We can change the group mean, but there's still individuals with decision-making capacity on both sides of your probability distribution who are going to be affected by this, and knowing how they are affected as well and planning on what's going to happen when they are affected by that is important to know. And then, like I said, having stakeholders in the room is good, but engaged stakeholders only represent engaged stakeholders, which is good, and they are necessary, but they're often not sufficient, right? You really need to know who's not showing up at your planning meetings and what they have to do with the overall system, right? Like I said, if the ability to affect the reuse of an operating room involves someone if there's someone who has to flip a switch every time an operating room is done, but that all they have to do is flip a switch and they're a very small piece of it, but it's still an essential step for an operating room to be used again. You definitely need someone who flips that switch in your model an implementation development group, right? No matter how small they are, if they can just kill your model. So another thing is there's a big regulatory aspect of this, and Duke, can I move myself over? Oh, I can. Has a internal regulatory and oversight thing called the ABCDS, and they publish some good work as well. So just be aware of them. If you do want to deploy, these are the folks that are going to say this model is safe enough to be deployed and none of that. I see. Oh, Shelley, for the engineering team, you find there are specific competencies that are most helpful. Experience is what I would say. Having experienced or managed or dealt with clinical data or health system data. It's not, I like to use the phrase, it is, and we'll get to this a little bit, it is unique, but it's not special. And so the more experience with healthcare you have, the less you need to kind of understand how stuff is going to be used. That would be the most helpful. But again, these are all necessary but not sufficient things to be useful in that context. Okay, shared assumptions between the model and the user. What do I mean? So I kind of alluded to this before, but here's some data from our operating room. Like, so this graph just really show how long a surgical case is going to take, right? This is before we deploy this model. And so before, and then we say scheduler, that's the person who actually said how long a case was going to take, but there's a lot of impact into that, right? So we were calling this the scheduler time, right? But it's not just the scheduler, right? They are responding to multiple, and so to explain this graph, red means that, and I see Ahmed is on, he can tell me if I'm correct, because I always get this backwards, but red means that the time predicted to take, that the operating room case was going to take, the time predicted was less than the actual time it took. White means that you were within 20% of how long the case took, and blue means that for instance, we put down on the planning chart that a case was going to take an hour, and only took 30 minutes, right? That would be blue. If it was we said it was going to take 30 minutes, actually took an hour, that's red, right? And so health systems have different needs, but you do want those to be balanced, right? You want the same amount overage and the same under, right? Because you just want less bias, right? And you want that white thing to be as wide as possible. And so the schedulers were operating in a biased form, right? They were under predicting more than over predicting, and their under prediction was about the same as their actual case length, as how long actually their precise thing. And so the electronic medical record itself makes a prediction. It's fine, it's more balanced, but no one was using it. And so we thought we could do better, right? And so we had this model 1, model 2, and model 3. The details of these models are in our publicized paper, but it more balances it and it improves the accuracy, right? But all our model was trying to do was be more accurate. The schedulers were doing two things. They were trying to be as accurate as they could, but they were also trying to, because the surgeons and the health system was asking them to do it, schedule as many cases as possible, as reasonable, right? So they were doing two things, and our model is only doing one. And so it's important to note they weren't doing something wrong. They were responding to the incentives that were placed in front of them. And we were trying to balance that out. And so what does it look like when the assumptions between the model and the users are the same, right? Hopefully it looks something like this, right? So August of 2021 was when this got, no, 2022, sorry, was when it was turned on and everyone had to use it. And that's that red line, right? So people were getting better from it, but you can see there's a break and so the error between the model prediction and the actual time put in the surgical planning thing is that error on the y-axis, right? And 0 is the model says this, the time that made it into the electronic record is this. It's not the accuracy, it's just the we call it compliance with the model output. And so as you can see that we want it to asymptote to 0. We want everyone to be using our model. And if they're not, we would like to know why. And a lot of this comes from administrative support, right? So the leadership of Department of Surgery said, we want everyone to use the model. Not just, let's just see if everyone uses it. It's, no, you have to use it. If you don't use it, you need a reason why. And so that's not in a modeling thing. That's a big piece of people using your technology is that leadership and administration says, no, we want you to use it, and you have to explain why you don't, right? And so that kind of aligns incentives. Because again, our goal was not to make, overall, to be clear, I'm not saying anyone was doing a bad job. I think everyone was doing different jobs. And so we wanted everyone to be doing the same, have the same goals, and the modeling allowed us to give kind of a consistent way of doing it. So we were trying to make, so those who do fluid dynamics, right? I want consistent flow. And from consistency, I can make it go faster. I'm not trying to make things go faster or more accurate. I'm just trying to make a consistency, right? So when there's a flu outbreak or a gastroenteritis outbreak in the people who make these decisions, what was happening was there were months of effects because it was people just making guesses because there wasn't the people they usually dealt with, right, of how long these cases were going to take. And so we wanted to improve so that no matter who was sitting in front of the computer to make the decision of how long an operating room case was going to take, that it was more consistent in those predictions. And then the last piece is, yeah, right on time. To engineer is human, right? So Henry Petrosky, who was a well-known engineer here at Duke, wrote a book, which I recommend everyone read. But basically, the thesis of the book was that engineers are humans, but everyone's a human. And so the thing I said about how medicine is unique but not special, there is often a pushback of medicine is special because, well, if we do something wrong, someone dies. My usual response to that is, what is it you think engineers do, right? Engineers are very good at dealing with safety critical things, right? Did you drive a car over a bridge to get to work today? If you did, engineers helped with all pieces of that. So when engineers screw up, and the book To Engineer is Human is about engineering mistakes that led to casualties. When engineers mess up, people can get hurt. And so that part isn't unique about medicine. It's not special about that. But it is different in the quality of data and the kind of data you get. But that being said, clearly not me doing a lot of this work. It's all the other people who I work with. This is kind of an old acknowledgement slide, but think of there's double this amount of people who work with on this stuff now. But thank you for listening. I hope this was at least entertaining. And I look forward to seeing your coffee, but I will answer questions on this for those who are not on campus.